A man on a ventilator develops hypotension, tachycardia, and a unilateral absence of breath sounds. What is your likely diagnosis? Hey guys, how you going? And welcome to the 5th episode of 5 Minute Medicine. My name is Kay, and I'm a medical student who's created this podcast to give you the highest of high-yield info on pathologies in only 5 minutes. So before we get started with the episode, go over and give our Instagram a follow as we'll be posting quizzes from the podcast and notes from the topic to help you excel in your studies. Our @ is 5.min.medicine. If you haven't guessed by the case already, as you guys requested, today's pathology is on pneumothorax. So before we talk about what a pneumothorax actually is, I thought it'd be helpful to first revise the basic anatomy of the lung. So superficial to the lung are the pleura. These are serous membranes, and essentially they sort of fold back onto themselves like a balloon to surround the lung. The space between the layers of the balloon is called the pleural cavity. Now, the layer closest to the lung is known as the visceral pleura, and the other is the parietal pleura. The pressure within this cavity is less than the pressure within the lung. What this does is allow the lung to push against this space, holding it open. Now, a pneumothorax occurs when air enters the pleural space, leading to a loss of negative pressure between the two pleural membranes. It can be classified into spontaneous, which can have primary and secondary causes, or traumatic. Traumatic pneumothorax can be divided into open and closed. Open occurs when air enters the pleural space through a hole in the lung, whereas a closed pneumothorax occurs when air enters through the chest wall. Now, there's a very important kind of pneumothorax known as a tension pneumothorax that we should talk about. This is a life-threatening variant that is characterized by increasing pressure in the chest, leading to cardiorespiratory implications. Any type of pneumothorax can lead to this. A tension pneumothorax occurs when a hole in the visceral or parietal pleura creates a one-way valve mechanism into the pleural cavity. This one-way valve creates some nasty problems. So, air enters the pleural cavity, but does not exit. This increases positive pressure in the chest, basically inflating the pleural cavity. The ipsilateral lung collapses, and this high pressure causes contralateral compression of the trachea, heart, and superior vena cava. The outcomes of this are quite predictable. Inspiratory function is impaired, cardiac output is reduced, and this results in hypoxia and hemodynamic instability. The key clinical features of a pneumothorax are super easy to remember with the simple mnemonic. The mnemonic is P thorax. So P stands for pleuritic ipsilateral pain, T for tracheal deviation, H for hyperresonance, O for onset sudden, R for reduced breath sounds and dyspnea, A for absent fremitus, and X for X-ray shows collapse of the lung. In a tension pneumothorax, additional findings include distended neck veins and signs of hemodynamic instability. Diagnosis of a pneumothorax is done through chest X-ray. It is important to note though that if you're a doctor and someone comes into ED with a suspected tension pneumothorax, immediately decompress their chest. Treatment of a tension pneumothorax involves immediate chest decompression using a technique known as emergency needle thoracostomy. This involves a long, large bore needle being inserted between the 4th to 5th intercostal space at the mid-axillary line. This should be followed by chest tube placement. Treatment of a stable spontaneous or traumatic pneumothorax is done with a chest tube. So that concludes our 5th episode. We hope you enjoyed listening, but most of all, we hope that you learned something too. So be sure to check out our previous episodes on endometriosis, ectopic pregnancy, pulmonary embolism, and appendicitis if you haven't already. Give our Instagram a follow. Our @ is 5.min.medicine. DM us for any questions, and happy studying.